Thank you very much. I start my screen. Okay. Can you see it?
Yeah, it's okay. Danke.
Okay. Thank you. Well, I'm Ingar Rohstock. I work at the health department in Düsseldorf at the section Social Psychiatry. And one big part of this section is the Social-psychiatric Service. And I would like to introduce to you this service today. First of all, I go to the legal framework, then I explain the target groups and what our tasks and offers of our service are. I like to explain our multidisciplinary professional team to you, and later on I go into network and into project work. Let's start with the legal framework. We have the law about public health service of the state of North Rhine-Westphalia. In German, it's ÖGDG. And this law is saying that the public health department provides a social psychiatric service to help people with mental and emotional disabilities or mentally ill and addicted persons and their relatives. This is a very important law for our work because this law is saying that every community in Germany has to provide a social psychiatric service. It's not an opportunity, it's a must-have. And this is the base of our work. Then we have the law about assistance and protective measures in the event of mental health. We call it PsychKG in Germany. And this law is regulating or declining what we have to do at the social psychiatric service. So it is a regulation of forced admission of mentally ill people in acute danger to themselves or others in a psychiatric hospital. This is happening often after, for example, a suicide attempt. It has general regulations of assistance measures, and it says how prevention and aftercare has to be done, and says everything about the responsibility and the cost of the social psychiatric service. Then we have the German Civil Code. In Germany, we say BGB. And this one is saying if a person of full age, by reason of a mental illness or physical, mental or psychological handicap, cannot in whole or in part take care of his affairs, the custodianship court on his application or of its own motion appoints a custodian for him. This is one of our most important offers and tasks. We have often clients who can't take care of themselves because of a chronic psychiatric disease. And in this case, we have to go to custodian court and ask for a custodianship for them. Then we have a lot of several social laws, SGB in Germany. They are all very important for our work. I can't go into every single one of this now, but you can see SGB 9 and 12, they are the most important social law codes for us. And then you see the red mark, child and youth welfare. This became very important for us because we started a new project. I will introduce the project to you later. That was just a short introduction into our legal framework about the laws that are most important for our work. Our target group are people with psychiatric diseases or addictions. So we count addictions to psychiatric diseases, and they all have chronic psychiatric diseases and are not able to find their way into our help system that we provide for them in Düsseldorf or in other cities or communities in Germany. And our clients often don't have any disease or treatment inside. So they, because of their disease, they show disease-related behavior. They are about to lose their flats. They are about to miss very important appointments, and this is all going to that they can't take care of themselves anymore. And our most important job is to maintain the physical and the socio-cultural subsistence level for our clients. Our clients are 18 years or older. We also take care of minors, but only in the event of immediate danger. For example, if we have any suicide attempts. What are our tasks and offers? We provide low threshold information about psychiatric health and about our help system. We do a lot of counseling and support, and very important is that we provide prospective help. So we visit them at home, we do house calls, we accompany our clients to appointments. We do crisis intervention. So we have a standby service within business hours. We would like to provide it 24/7, but this is very expensive. We can't provide it now. Crisis intervention means that our clients are in acute danger, that they try to commit suicide, or that they are a hazard for other people. So then we need to go in contact with them and need to decide if they have to go to a psychiatric hospital. If they have to go to a psychiatric hospital, we provide aftercare as soon as they leave the hospital again. We work closely together with the hospitals, and our goal is to transfer our clients into the further help system. We have a navigation function here. We do offer support groups, get together, and group therapy, and we do offer sociotherapy. We are also doing supportive counseling to the relatives and the social network or the social environment of our clients. And important is the preparation of medical certification statements and social reports for custodian applications. That's what I said before. When our clients can't take care of themselves anymore, we have to go and ask for custodianship for them, and therefore we need this medical certification. We do counseling and teaching of skilled labor. What we are doing has no fees. It's free for everybody. And important is also networking and prevention work, of course. What we are doing, our work in the Social-psychiatric Service, is caught between control and help. We have a very tensed field here, because on the one hand, we have the free will and the freedom of our clients. On the other hand, we have disease-related behavior, and this disease-related behavior is not at all going along with the expectations of the social environment. So we often have clients who live in a messy flat with rats around them, and then we have the neighbors, and the neighbors see a health problem for themselves there. So this is quite a tensed working field here. We try to intervene, but our clients often don't want us to intervene. So our most important job is the protection of our clients, of the individual, personal and external hazard. We are doing this in a multidisciplinary professional team. So we have psychiatrists working at the Social-psychiatric Service. We also have psychologists and psychological psychotherapists. We have one child and adolescent psychotherapist. That's quite new. That's very important for the project I introduce later on. We have lots of social workers and social pedagogues and nurses, but of course also administrative staff. And they are all working hand in hand together. So we have quite a lot of professional background. we are working together with a whole lot of people and organizations. You can see them here on my slide. Very important are the psychiatric hospitals, but also the police, the judges, the courts, and of course, lots of organizations here in Düsseldorf who provide help and work with our clients. So we try to connect our clients with the further help system that is already there. We do a lot of committee work, and the most important part of the committee work is that we have an information transfer to the municipal and political committees, because we have to make sure that that everyone sees the importance of our work, of the psychiatric health. We have working groups for specific topics like system pressures, for example. And we do cross-agency prevention work. We work together with the youth welfare. We work together with the Office for Social Affairs and the Office for Migration and Integration. We have currently 7 different projects going on at the Social-psychiatric Service. The first 2 projects, Sector Plus and finally a Home, are projects that focus on homeless people with mental diseases. So we try to get them off the streets and into a home. And then we have 2 projects, Psychosocial Clearing and Counseling and Rehab, and they are focusing on unemployed people with psychosocial rehabilitation needs or unemployed mentally ill people. We are doing all these projects together with other agencies. One important project is Confido. Confido focus on children of mentally ill and addicted parents. And we do this in cooperation with the Youth Welfare Office. So we provide counseling to for the people, for the parents, and the youth welfare takes care of the children here in this project. Then we have Atrium. Atrium is focusing on mentally burdened and mentally ill migrants. And the last project is the one that I'd like to introduce to you a bit further. It's a counseling center for strengthening the mental health of children, adolescents, and young adults. This counseling center started in December 2020, so it's going for a year now, or almost a year, and it's the same thing like the Social-psychiatric Service, but this one is focusing on children, adolescents, and young adults with mentally diseases. We have the same thing here. These children and adolescents can't find their way into the help system on their own, so they need help. They need us as a navigation function. And we often have children or adults who act as so-called system crashers. So who don't go to school, who don't want any help, who stay at home, or being criminal because of a mentally disease. We also support parents, relatives, and the social environment, of course. And we have 5 big points in this project. The first point is the development of a child and adolescent psychiatric service. So we work together here with the youth welfare. We are bundling psychological skills in this field. The Social-psychiatric Service is providing specialists on the subject mentally ill parents. And of course, we create a low threshold offer as part of the Child and Adolescent Psychiatric Service. So what are we doing? We are doing almost the same thing what the Social-psychiatric Service is doing. We do supportive counseling. giving advice on social law issues. We're doing prospective help. Again, we visit them at home. We accompany them to appointments. We do crisis intervention and suicidal crisis and aftercare if our clients had to go to a psychiatric hospital. We also do anonymized case advice for professionals and try to connect our clients to the help system that's already there. Diagnostic counseling and crisis discussion is something that is new to us, and psychiatric assessment as well here in this field. And of course, we do prevention work and further education of skilled labor. We want to do an expansion of the digital information and counseling service. We do have already a website and email, of course, and people can come to us and have counseling on the phone. But what we want to create is something like a chat function, because our clients are so-called digital natives, and it is easier for them to get in contact with us on the internet than in person. Then we go into schools and teach pupils about psychiatric diseases. So we do this using the so-called Mind Matters materials. These materials are originally from Australia. And we train the teachers to work with these materials, to teach pupils what psychiatric diseases are and what you can do about it. And then we go to school and answer questions and explain the help system we have here. Networking is, of course, a very important part of this. We do work together here with the youth welfare. We have participation in the prevention group. So prevention is a very big thing here. And try to present our work and connect it to municipal work. We have a special focus on system crashes. So one very important thing is that we try to create a concept to prevention and intervention of system crashes. And the last point is that we want to create a teaching tool for labored staff about in different kinds, like in kindergarten or in schools, that the staff has a teaching tool and get informed about psychiatric diseases of children, adolescents, and young adults, and what they can do about it, and how the help system looks like. Our cooperation partners, and thank you very much for your attention.
Thank you very much for your presentation, Inga. I have a question about it.
Yes.
So correct me if I'm wrong, but it seems to be that the way the service is working is pretty much top-down. Now, my question is, how do you make sure that the clients or patients know how to find you? And second of all, if they are participating, how do you keep them internal motivated?
Our clients are not coming to us on their own free will. This is why they need us, because our clients are children and adolescents who stay at home, not leaving the bed, not going to any psychiatrist, not going to any psychologist or doctor, not going to school anymore, just staying at home doing nothing. So often schools are calling us because they are worried about the pupils, or the parents or other persons are calling who are related to our clients, and then we try to get a connection to them. We try to get them into the help, so that they that's the first step into the help system. we accompany them into the help system. But it's really, it's often against the will. So it takes us a long time to get a connection to our clients.
So it's really specific target group.
Yes, it's a very specific target group, yes.
Okay, thank you. Are there any more questions? Nobody? No? Then I would like... Yeah, you?
Well, I was interested in this paragraph 20 because we learned from the prevention paragraph. We learned from Germany that they have included in this paragraph 20 also self-help. And there is a specific amount of money that is voted every year for self-help, which is great because it stimulates infrastructure in North Rhine-Westphalia in which there are 40 contactstellen for self-help. But I was wondering, Inga, is there also an amount of money connected to the ruling you have within this paragraph 20? So how much money is made available for the work you have to do?
For the work with the children or for the work with the adults? Because
the adults.
I can't really say the amount of money that we have. We have about 20 co-workers, social workers, and what they are doing is, so the amount of money we have is to pay the co-workers and what they are doing. But we don't have much more money for any projects. We need to go to other. So the project with the children is from it's not from the community. The money, yes.
Yes. Okay. So, and you get it from the Krankenkasse.
No, this is the community has to pay for the Social-psychiatric Service.
Okay.
Yes.
It was just to understand because
okay.
I mean the service is perfect, which you presented, and that's a difference I think between the Netherlands and your country, where this is within the public health services, while in the Netherlands it is, as I understand it, included in the, let's say, in the Zorgverzekeringswet, so in laws that are paid by the Krankenkasse.
Okay.
Thank you. Thank you very much.
You're welcome.
I see that Fabian has a question. Fabian?
Yeah, thank you. Not really a question though. Now, given the time, it's 10 to 12. I'd like to thank each speaker, and of course, I found all three presentations highly interesting. My problem now is we, as an international audience now, I think the real interchange now would lie in communicating about what we heard of and giving our different perspectives here. And now we only have 10 minutes left, and I think it's really a pity because now we got really lots of incentives for discussion, I think, and we're not actually being able to have one. So probably either I got the concept wrong, or next time I would suggest we have more time to evaluate what we heard. I would have lots of speaking points here, being a social assistant in Krefeld, Germany, and sometimes working with the Social-psychiatric Service, and often lacking infrastructural funding in my work with mentally disabled clients. So we often have problems in terms of they would like to do sports, for example. They should do sports, it would be good for them, but there aren't any real places they could go in the city. Thank you. That's just one point.
Well, maybe we can start kind of a discussion right now. I don't know if you have any other things you would like to drop.
Maybe I can also say something about that, Fabian, because I understand completely what you said. And in the former workshops, we did have interaction groups, but we found out that the majority of the people, because of digital, find it rather difficult to discuss it in this way. So what we decided is that we're going to try to do it in a different way. And as I said in the beginning, we also have the option for internships, where if you, for example, and we could do that maybe also for you, as if you are interested, that you tell us where you want to go, for example, in which organization or what is the topic, so that we can see if you can have an exchange with somebody working with that person. Because again, as I said, networking is very often difficult via a digital platform. We have found out that is the reason that we had that the way you said it, and then we found out it didn't really work, so that we moved back to the way we do it right now. But maybe there are other people also that are interested in having a more in-depth discussion also across the border with other people. Tell us, let us know what you need, so that we also can integrate that in the project and maybe see what we can do for you, because that's what we want. It's not, we are not just throwing information about over the fence, as we would say in the Netherlands, but we would like to help you achieve your goals. And if that is like Fabian asked, to maybe do it also in a different way, or organize a physical meeting with a few of you, 3, 4 people, doesn't matter, let us know, because that's what we can do.
Yeah, you still have a question, Fabian, because your hand is still up.
Yeah, I would suggest, given that both the first speaker and the second suggested to lessen the bureaucracy around health services, that we somehow come up with a workshop or working group as to how can institutions lessen bureaucracy and apply more hands-on approaches. I mean, across the board, across the range, like from small institutions like mine with 20 employees or 25 in social health, up to the big founding organizations or ministries of health, like all across the whole range. How can we lessen bureaucracy and be more hands-on? Because I think Klaasien obviously had some great ideas about this, but it was just so compact. A presentation, there were so many things she barely touched upon, but I think that's really food for thought there. Thank you.
Yeah,
maybe can I say something? Sorry?
Yeah, sure.
Yes.
Okay. I think that's a very nice idea, and I think maybe it's also already nice to make an inventory of how you as professionals already now try to circumvent all these bureaucratic standards, because I think you have a lot of, say, local and informal knowledge about how to escape all the bureaucratic measures. And that's also very interesting to see, because that's, I think, part of the knowledge that you have and that is enabling you to reach people and to be in touch is in fact how you escape the bureaucracy. And you have a repertoire and you know how to do it. And I know from people in home care who are not allowed, say, to sit in one car with patients, for instance, or clients. And I know from people who do it all the time to help them to get from A to B or to bring them to a dentist or whatsoever. So they break rules also. But they have to do it because they help people. And maybe you can simply already make an inventory of your own, say, informal knowledge in doing these things already, and sharing it would be nice. Yeah.
Yeah, thank you very much. I totally agree. I think we, as a project group, should take this with us and discuss how we can give form to it, so to speak.
Yeah.
So, I think that's a nice way to end this workshop and the presentations. I would like to thank all the speakers for their contribution. I would also like to thank all the participants for your participation and also your contribution. And we as a project group will take this with us, and hopefully we can make something out of it. You will hear about it anyway. So thank you very much. And I would like to end the workshop.
Thank you. Bye-bye. Have a nice day, all of you. And thanks again for your participation.
Bye-bye.